These and other payoffs of basic and applied research are now being translated to the developing world through important programs such as the President's Emergency Plan for AIDS Relief, or PEPFAR, the Global Fund to Fight AIDS, TB, and Malaria, the Gates Foundation, the Clinton Foundation, and others. TB has benefited in part from these programs, but largely because it is an important comorbidity with HIV, and I'll get to that in a moment. To me, the key question for this meeting is, why do we not have 30 new drugs for TB, a disease that we know is eminently curable? There are a lot of complex answers to that question, but one of them surely is that a transforming research effort in tuberculosis has not been evident, but that is beginning to change. We are seeing, as it were, the winds of change, but what we really need is a storm. Of note, there have been at least 2 events or circumstances that have called attention to TB. These have impacted the investment of resources and the interest in TB research, at least in the United States. The first was the increase in TB cases that occurred in the United States and in other developed countries, almost exclusively as co-infections with HIV during the late 1980s and early 1990s. Some of these cases were MDR, an ominous early sign of what was to come. However, it was the more frequent occurrence and spread of MDR and XDR-TB during the past several years that has caught the attention of the world and has sparked a heightened interest in addressing this problem by a multi-pronged approach, including biomedical research. Now, human nature being what human nature is, it was largely the fear that it would become our problem. That is, the developed world's problem, and that woke up us and other rich countries. This is best reflected in the events that followed the incident of a U.S. citizen who was thought to have XDR-TB, who took transatlantic flights with his fiancée. I and my counterparts at the CDC were called to testify several times in front of Senate and House committees on the dangers of flying in airplanes with people who might have TB. So it actually became a national security issue. I seized the opportunity to inform my esteemed colleagues in Congress that given their heavy international travel schedules, essentially all of them have certainly traveled on airplanes with people who were infected with TB, since 1/3 of the entire world is infected with MTB, and nearly 14 million people have active TB, and that MDR and XDR-TB were part of a problem much larger than safety during international flights. These legislators who control our research budget are smart people, and that got their attention. Indeed, we in the scientific community are among only a small group of constituents with the opportunity and the forum to speak up when it comes to diseases that affect predominantly people in poor countries. And so I believe that the stage is being set. Thus, it is time to transform the toolkit that biomedical research can provide in the multifaceted approach to the control of global TB. Again, and I want to emphasize this, I am totally aware that the implementation of existing methods and the application of existing tools can and does have a major impact right now. In fact, in recent discussions with a valued colleague whom I tried to convince to devote some of his time to TB research, I was told that we already have everything we need to control TB, and so he would rather concentrate his research efforts on other problems. I respectfully disagree. Taking that argument to its logical conclusion, one can say that during the early years of the AIDS pandemic, we had everything that we needed to control HIV infection. Just avoid risk behavior. That certainly is important, but not at all feasible. It is critical for us to transform diagnosis, treatment, prevention, and control of TB with biomedical research to the same extent that we have done and will continue to do with HIV/AIDS. For certain, MDR and XDR-TB have been the crisis and the trigger to expand our TB research agenda, and that's what this meeting is essentially all about. So in this regard, the $665,000 NIAID investment in TB research in 1985 has grown to $130 million in 2008, with still more to come despite constraints on our budget. This is appropriate, since the opportunities are extraordinary and those in the TB field are playing catch-up with other fields that have benefited from the 21st century research agendas with their transforming technologies. In 2007, NIAID developed and made available online a research agenda for drug-resistant TB, and we subsequently published it in an article in June of 2008 in the Journal of Infectious Diseases, where we described that agenda. We've identified 6 key areas in which there are significant gaps in our knowledge and our armamentarium that need to be addressed rapidly in order to combat the emergence of MDR-XDR-TB. The research agenda is not a surprise to the people in this room, as it recommends what we've all been talking about: the development of new diagnostics, the better use of existing drugs, and the development of newer drugs, understanding basic biology and immunology of host pathogen interactions, a better understanding of the epidemiology of TB, and improving the treatment and clinical management of patients co-infected with HIV and other diseases, and finally, the development of effective preventive strategies that recognize the differences between drug-sensitive and drug-resistant TB, as well as the development of vaccines. Now, all of the details of this is available on our website that many of you know, www.niaid.nih.gov, so I'm not going to go into it in detail, since you can do this at your own leisure. However, I do want to take a 30,000-foot perspective for a couple of minutes of the opportunities that biomedical research can and will provide, as well as underscore some specific challenges and needs that I am sure are apparent to all of you. First, getting back to the broader perspective, we should look to transform the field of TB research. We must not take just an incremental approach to another drug and another diagnostic, which is important, I grant you that, and a lot of progress is being done. TB is an ancient disease, but we need to understand it in modern terms and use cutting-edge technologies to ask and answer questions that were never addressed in the first place, because we felt that we had good drugs that we could use to cure the disease. For example, we need to understand TB as a disease of the whole organism, namely the patient. Some call this a systems biology approach. Call it what you wish. In this regard, we need to understand much better the delicate balance between the host and pathogen in the context of the entire biological system.